Hello and welcome to CDP Presents, our monthly webinar series. We're happy to have all of you with us today, and if you've joined us before, welcome back. I'm your host for today, Andy Santinello, consultant with the Center for Deployment Psychology and assistant professor at the Uniformed Services University, and a part of the CDP Presents team. This project is sponsored by the Uniformed Services University. However, the information or content and conclusions do not necessarily represent the official position or policy of, nor should any official government endorsement be inferred on a part of USU, the Department of Defense, or the US government. Here's a good snapshot of some of the upcoming trainings that will be offered in the next couple of months, which can be found under the training tab on the CDP's website. We wanted to highlight a fantastic and free training opportunity that's being offered 3 times this year, training on assessment of PTSD and suicide risk management in veterans. And this is funded by the PTSD Consultation Project at VA's National Center for PTSD and presented in collaboration with VA's Suicide Risk Management Consultation Program, as well as the Center for Deployment Psychology. This 2-day workshop aims to introduce participants to military culture and also to help them develop skills in assessing for 2 really important clinical issues that are very relevant to this population: post-traumatic stress disorder and suicide risk. For more information and to begin the application process, please visit the website at the bottom of this slide. Please note that only licensed behavioral health providers who regularly treat U.S. veterans or who intend to treat U.S. veterans in the community can apply. This training is not intended for behavioral health care providers currently working in VA or DoD settings. There are still plenty of slots available for the February training, so take advantage of this great opportunity. In addition to being free, this training offers 14 credits through APA, continuing education credits through APA, NASW, and ACE. So if you're looking for 14 free credits and some really fantastic training, we hope that you will seriously consider signing up for this workshop. We're also really excited to announce that registration is now open for our 2023 Evidence-Based Psychotherapy Conference, which is going to be titled Answering the Call with Focus, Flexibility, and Fidelity, Implementing EBPs in the Wake of Public Health Crises. And this is going to take place on May 11th. We have a fantastic lineup, including our keynote speaker, Dr. George Bonanno. Pre-meeting EBP workshops are also available May 9th through 10th, which include acceptance and commitment therapy, which I will be facilitating, cognitive behavior therapy, as well as motivational interviewing. So please scan the QR code or go to the link at the bottom of this slide for more information. If you missed last month's webinar, never fear, we have you covered. You can find the recording on our archived webinars page. And if you attended and liked the webinar, please feel free to share it with your colleagues and friends. Also, if you're not already familiar with it, CDP just wrapped up our 2nd season of the podcast, podcast Practical for Your Practice. So this biweekly podcast features stories, ideas, support, and actionable intel to empower providers to keep working towards implementing evidence-based psychotherapies with fidelity and effectiveness. And season 3 just launched earlier this month. And seasons 1 and 2 are archived and available for binge listening if you connect with it. And actually, our guest today, who I'll introduce to you in a little bit, has been a guest on our podcast before. So if you really connect with the topic that Dr. Rhodes is talking about today, and you'd like to learn a bit more about ACT and how it might be relevant to practice in sort of a healthcare setting, we've got a really great episode with her from season 2. Okay, so before I introduce our speaker for today, formally, I wanted to take a few moments to just orient you to some of the features of Zoom that will enhance your experience of our training. So you may have entered the webinar in full screen mode, and if you'd like to exit full screen mode, just click anywhere on your screen and hit the escape key. For the best user experience today, we recommend that you close all other programs on your computer. Any difficulties viewing the material during the presentation are likely due to a poor internet connection. While I'm talking, please check the volume level on your computer or device and adjust as needed. Many participants are going to find it easier to hear the presentation by using headphones. Please note the chat feature, which you can find by hovering over the bottom of the screen. This is a really great place for you to enter questions and respond to questions that our speaker may pose, or even interact with other participants. Questions will be moderated and asked of the presenter in the final few minutes of the presentation today. Dr. Rhodes might also answer some questions on the fly, so please don't hesitate to put your questions in that chat pod. Also, if you experience any technical difficulties today, please type the problem in the chat pod and someone from our tech team will reach out to support you. Please make sure that you send all of your messages to all participants and attendees in the chat pod so that everyone can see your questions. This webinar series will be recorded and posted to the Center for Deployment Psychology website with any additional materials and references. Handouts for today's webinar can be found in your CE21 My Account page under this event. Finally, at the end of our webinar, our program manager, Dr. Micah Norgard, will provide information and instructions on how to obtain CEs. In order to obtain CE credit, you must attend the entire webinar and complete the webinar survey in CE21. Please note that for this webinar, we're offering American Psychological Association CE credits, which are acceptable to most state licensing boards for different mental health disciplines. Please be sure to check the requirements of your state and retain any documentation associated with this training. All right. So I'm very excited and happy to present or introduce you to our presenter today, Dr. Amanda Rhodes. Amanda Rhodes is a licensed psychologist and holds a primary faculty appointment at the National Institutes of Health, where her research agenda focuses on acceptance and commitment therapy for cancer, pain, and other chronic illnesses. She owns an ACT for Pain-focused private practice in Bethesda, Maryland. Amanda is founder of the ACT Academy for Behavioral Health, a consulting firm aimed at training practitioners in ACT and other contextual behavioral approaches. Amanda currently serves as president for both the Mid-Atlantic chapter and cancer special interest groups of the Association for Contextual Behavioral Science. Dr. Rhodes has no financial interest to disclose. So with that, I'll hand over the virtual mic to Dr. Rhodes.
Thank you, Andy. Let's see. Okay. I have control now. All right. Hello, everyone. It is 12 o'clock East Coast time, but I'm seeing people from all around the entire United States. So it's morning time on the West Coast, which is amazing. I'm so happy to be here and to give you this webinar today and to talk about this topic that I just love. And I have had my feet deep in for many, many years. This is an approach that I have found in my time as a clinical psychologist to fit so well with our pain populations, particularly our chronic illness populations. Today, I'm going to be focusing on pain specifically and how we might conceptualize pain and then interventions towards pain, including some resources along the way. So the talk is called Psychological Flexibility and ACT for Chronic Pain, Theory and Application. And I have no disclosures. So in terms of agenda, what we're going to be doing over the next hour, hour and a half, first, we're going to talk about systems and context, because it's really important, I think, when we talk about pain and our patients that experience pain, to understand the medical model that they are embedded in, particularly in the United States and Canada. This is very important to understand their pain experience and how the messages that they might be getting on the day-to-day might be impacting their experience with pain. And this radically a different approach that I'm going to be introducing today. Then we're going to talk about a little bit what is pain and chronic pain, what is acute pain, and then also some of the things that, some of the nuances that I see or that we see that come up with the pain population specifically, that you might just want to take a special note of if you're going to work with this population. Then we're going to go into actual clinical intervention for pain. So this is an ACT workshop. If we have some time, we're going to do some case conceptualization. I'm going to show you how I might conceptualize a patient coming into my door from this perspective, and then some interventions that I might do along the way. And the cases I use, I've changed their names, but they are real humans that I have seen in my office. And if we have time for questions and discussions at the end, or of course, like Andy said, I'm happy to answer any questions outside over email, or I'll give you my contact information at that. I'm going to do my best to monitor the chat. Andy's also going to monitor the chat. I'm going to try. We'll see. If I miss it, just hold tight and Andy will kind of bring it around, or I'll get back to you on it. Okay. So let's see. So in terms of the system of the medical model in the United States, it's really important to understand that human suffering as a total is often presented as this materialistic paradigm. And what I mean by materialistic paradigm is that it's often thought that the cause of human suffering is because of a lack of material standards. So something like the lack of access to healthcare, or lack of medication, or bad working environments, or lack of free time. But it's really interesting to understand what is the actual relationship between illness and pain and health-seeking behavior or sick leave. And does increasing access to healthcare decrease suffering? So Western healthcare systems are built on identifying and solving acute problems, right, in short term, so that we can have short-term alleviation and avoidance of symptoms. However, when things improve, do those sufferings still exist, right? We can use Europe as a really interesting example. There is little evidence that the rapid development in Europe of the national healthcare insurance system in the EU has significantly influenced the general health or suffering in the population there, which I think is really interesting. Those kind of things have been measured by like life expectancy, perinatal and infancy mortality, deaths due to heart disease, cancer, and those things have not significantly improved with the social welfare system. So if human suffering is not eliminated by the expansion of traditional healthcare services, what will be? So let's sit on this quote for a second, which is pain, stress, anxiety, or difficulty should not or cannot be part of a meaningful, healthy human life. These are the messages that we often give out and get as humans. Right? And these messages are particularly mixed with gender role expectations, which seem to particularly impact women, which are overrepresented in pain populations. The medical model of chronic illness, and particularly pain, is at the forefront of this work. It is particularly in the United States, what we see on a day-to-day basis. So when a patient or a client comes into my office, I have to understand that they have a long learning history, very likely with this medical model of pain before they've gotten to me. So that helps me get an understanding of how they are conceptualizing their experience and their pain in the moment. So I'm going to give you a brief overview of the medical model of pain, because it's really important as we switch into this new way of thinking, or a different way of thinking, if you're interested in it. So in the medical model of pain is either somatic, real, or it's psychogenic, or another term we might use is psychosomatic, not real. So this philosophy is mechanistic. And what I mean by mechanistic is that there are defective parts, relations, forces that cause particular signs and symptoms to occur. So if we work backwards from signs and symptoms to identifying underlying pathology and then cure the pathology, we will ameliorate its impact. That's really cool when it works. So some of the challenges that show up with that is that when multiple forms of physical pathology produce common signs of symptoms, like, what? Which one is it? Or when a behavioral learning history interacts with physical pathology to produce signs and symptoms. Or a challenge is when there's behavioral learning history and signs and symptoms producing multiple signs and symptoms and pathology. So it gets really confusing. So where do we intervene? This tends to be why chronic pain often is not solved, because it's so complicated. So within this medical model of chronic pain and pain treatment, there are these Western approaches to pain treatment, like analgesic drugs, painkillers, non-steroid anti-inflammatory drugs, muscle relaxants, antidepressants, epidural steroid injections. And it's really awesome when they work and it does well, and oftentimes they don't. And if patients and clients are coming to us for pain, a lot of times it's because those things haven't worked. And so what's left? It's important to understand that human beings are extremely complex. Yes, they are biological. So when we fix the pathology and it ameliorates the impact, that's awesome. But we also are developmental. We have learning histories. We language things, and that language and cognition impacts the way we show up to the world. So overall, it's really important to understand, as you all know, as practitioners, human beings are incredibly complex. And so something like the simple medical model to chronic pain may not be working for everybody. There are 3 different types of pain. So we have nociceptive pain, and that is pain that is the type of pain that's caused by damage to body tissue. And it's often a sharp, aching, throbbing feeling. And it's often caused by like an external injury, like stubbing your toe or a sports injury or a dental procedure or a cut or something like that. We also have neurogenic or neuropathic pain. Most people know that term more, which is due to dysfunction in the peripheral or central nervous system. And that ends up being more like a shooting or burning pain, sometimes a tingling or numbness type pain. And that's often chronic. And that's sometimes the result of nerve damage, like something like phantom limb pain, which I'm going to use in my case example if we get to it at the end. And then we have psychosomatic or psychogenic pain, right? And this is thought to be a pain disorder attributed solely to psychological factors. Traditionally, that has been beliefs, fears, strong emotions. So the distinctions between these types of pain seem intellectually clear, and sometimes they are, but they imply that most pain symptoms can be traced back to either two pathological aspects of the nervous system or to psychological causes. An alternative to the medical model for pain is this biopsychosocial model. And I'm not going to go too much into it because I think we all know what the biopsychosocial model is, but it's an interesting juxtaposition to strictly the medical model. And I think it really gives us the groundwork to do great works as therapists and as social sciences and behavioral health practitioners. And so when we think about biological factors like physical health, genetic vulnerabilities, it's interacting with psychological factors like mental health, social skills, behaviors, emotions, which are interacting with peers, family dynamics, family relationships, education, SES. And so we can think of the pain experience within this biopsychosocial model. The social factor I want to highlight particularly because in pain work, the system in which we are experiencing and living our life is particularly important because pain does not live in a vacuum. And so a lot of that family dynamic system, healthcare provider, work dynamic systems is really important with our pain experience. When I do work with pain with kids, which is a whole nother topic for a whole nother day, I almost exclusively, if not like the major majority of my work is within the family system, because the pain, the experience of the pain with a child is functioning within that family system. And so I wanted to highlight that because it often does get kind of thrown off to the side. So I said there's Western approaches, traditional medical Western approaches to pain. Here are some non-pharmacological approaches to pain, which are things like rest and PT and OT, massage therapy, neurostimulation, which is like acupuncture or acupressure. And then there's psychosocial therapy or counseling. So we're going to focus today on this one. They all have their place. I have found acupuncture to be incredibly helpful for my own chronic pain. They all have the place. That's not my expertise. So we're going to focus really on this clinical intervention, the psychosocial aspect of counseling. So for psychological approaches to pain, there are several out there. So there's traditional CBT, third wave approaches, hypnosis, biofeedback. We're going to be focusing today particularly on ACT. We're going to do a little bit of background on CBT. I did just hear Dr. Santinello say that there's a CBT for chronic pain as part of one of the trainings coming up. Please attend if you're interested in it. That would be really, really cool. So I'm going to briefly focus on it, and it's definitely worth several hours of training. So particularly in CBT for chronic pain, it's going to be interesting as you notice some of the similarities in some of the systematic approaches that I just talked about, like that education about the nature of the disorder and the role that patients play in its management. And then there's this symptom self-management skills aspect that target things like pain and fatigue to decrease sleep issues. And then there's lifestyle changes promoting skills to target barriers to that change, like the unhelpful thinking strategies and the long-term maintenance, like stress management and goal setting, problem solving, reframing, communication skills, all that kind of stuff. This is the model for CBT for chronic pain. And instead of some intrusion of biological malfunction or infectious agent or toxic insult, behavioral therapists, particularly CBT therapists, they might posit that the pathogenic learning histories might generate negative thoughts and emotions and memories, bodily states, behavioral predispositions. And these kind of are could be the equivalent of the tumors, the viruses, the bacteria. So the CBT model of pain includes behavior, physiological and cognitive components that kind of all interact with each other. For example, the damaged tissue that results from falling off a horse may influence our thinking about horses and influence how we behave around horses or avoid behaving around horses. So the goal then in CBT for chronic pain is to reinforce productive behavior and to stop negative reinforcement and avoidance of behavior, while at the same time reducing the spread and the function of that stimuli that I just said that elicit the pain experience through something like classical conditioning. In this CBT approach, the principles and the targets of the intervention have a kind of expand from first wave to second wave to include negative feelings and thoughts, as well as more kind of the traditional behavioral goals from that first wave approach. And cognitive reframing, such as reframing dysfunctional thoughts, mental training for positive thinking, the use of mental distraction, and then also things like stress management, time management, relaxation, biofeedback, skills training, that kind of stuff. I really like this little chart here for the CBT model of pain. I think it does a really good job of understanding what we're trying to do as practitioners. And that traditional CBT model for chronic pain comprises of a group of kind of psychotherapeutic techniques and approaches that target thoughts, feelings, and actions that are considered negative or destructive. And the treatment is geared towards changing those through classical conditioning. So the therapist plays an active role in trying to manipulate or change factors that may increase pain or decrease pain. Ooh. One more. The VA has a really cool 12-session protocol for CBT for chronic pain. I did put the website there. So if you're interested, we're going to move on to ACT now. But if you are interested, first of all, go to those trainings. But the VA has really cool resources on CBT for chronic pain. So there is lots of research for CBT for chronic pain, lots of randomized control trials, and meta-analyses show that patients receiving CBT improved more compared to a waitlist control or groups that participate in other forms of treatment. What's interesting is CBT pain programs are almost always embedded in these multidisciplinary team approaches, which in itself are known to be helpful. Those kind of other aspects of those approaches. So it's almost impossible to know which specific components might be involved in those positive outcomes. But it is interesting, I have to say, that there is little empirical support for those cognitive mechanisms of CBT in this realm, and instead a lot of empirical support for the behavioral mechanisms. So that's just interesting and a new kind of bridge to why we might think about ACT for some people that aren't necessarily showing up in a way that we want to for CBT. So now we're going to look at ACT. And the reason why I gave that really brief background of CBT is because you're going to see how ACT is different now. They are both effective for chronic pain. They're both really cool. It's the patient-centered approach. So what might work with one patient might not work for the other. So now we're going to go on to acceptance and commitment therapy. ACT for chronic pain is considered an evidence-based approach. So the APA, the World Health Organization, the UK National Institute for Health and Care Excellence, the Australian Psychological Society, they all put chronic pain as strong research support or moderate certainty, or they recommend it for particularly the UK or the Australian Psychological Association recommends it for children, which I think is really cool. Overall, there's a lot of evidence and research support for ACT for chronic pain. So some of the evidence for ACT for chronic pain, and I apologize, I don't know why I don't have a reference on this slide, but pain acceptance, and that's a pillar of ACT that I'm going to talk about in a few minutes, is associated with lower pain intensity, less pain-related anxiety and avoidance, less depression, less physical and psychosocial disability, more daily uptime, which that I find very interesting, and better work status. And also interestingly, ACT is also effective at producing greater behavioral tolerance of acute pain and discomfort. I do a lot of work with patients with sickle cell disease, and with sickle cell disease, they go through something called a vaso-occlusive crisis, a VOC, a pain crisis, where they have intense bouts of acute pain, like nothing I've ever seen before. And so this is an approach that I use with my patients with sickle cell disease when they are out of their pain crisis because they have bone death and chronic pain, but they also have a lot of acute pain that is happening in the moment if you've ever seen somebody or talked to somebody that's in a pain crisis. I also wanted to add a little bit about veterans and military personnel because of the organization that is hosting me today. When I went to the literature and I did a little bit of uniformed services work a few years ago, and I found it highly influential in how I show up to my work now, because almost 48% of veterans in the VA system experience pain on a regular basis. That's a huge number. And pain is one of the most common reasons that veterans consult with their PCP. One study that I found saw that US soldiers screened within 90 days of returning from a 1-year combat tour. Yeah, that's right. 1-year combat tour were 2 to 4 times more likely to have migraine pain as compared to the general population. And some research also suggests that past military service may contribute to a hypersensitivity to pain symptoms, because it might be a hypersensitivity to sensation in general, which is then overlapping in how we experience pain. And a really interesting finding that I found was that employment status has been shown to be related to pain in military populations. What I mean by that is that the only statistically significant difference between groups in pain, non-pain, were employment status, not what you see with age or gender or sex, but employment status. And what they found was that actively employed patients in the military reported significantly less pain than those who were retired, receiving or applying for disability, or were no longer employed. This is a really interesting finding to me. I have somebody who's very close to me, very close to me in the military active duty. And he is a T-30 U-2 pilot. And so he goes supersonic speeds, G-force, all of that good stuff, right? And he has severe chronic back pain, as you can imagine from being a pilot. He goes to the chiropractor 3 times a week for pain. I called him as I was preparing for this presentation, and this has been an ongoing talk that we've had for many, many years about pain in the system, military, his experience. And he was like, well, yeah, my employer doesn't know that I go to the chiropractor 3 times a week for pain. And I was like, I was stopped in my tracks with that. And so that is an example of this research finding that is shown here. In veterans, ACT and CBT have comparable positive outcomes in veteran population on things like pain interference. Pain interference specifically is how much is pain or your experience with pain getting in the way of your daily life? That is a really interesting construct to me, because as an ACT practitioner, which I will talk about that values behavioral action construct in a second, as an ACT practitioner, I really want to know how pain is interfering with the things that you love doing. So that's a really interesting construct. But it's also depression, pain-related anxiety. They also have found, some studies have found that ACT, like in a group format, increases pain-related acceptance in veterans, and that even something like a 1-day ACT retreat showed efficacy for quicker cessation of pain and opiate use in at-risk veterans following surgery. So the message that most people in this world get is that get rid of pain. We give that message, our society, the things that we read, the things we see on television, the way we interact with healthcare system is get rid of it, get rid of pain. And in this kind of the feel good, no pain era, everything that our culture teaches us is to avoid pain at all costs. So ACT suggests something radically different. And it may be hard at first, and just stick with me if you're new to this. From an ACT perspective, patients get stuck while spending more and more time trying to control, manage, or alleviate their pain and stress symptoms, and less time being spent acting in valuable life activities or directions. So the symptoms of pain and stress begin to occupy clients' entire lives, and valuable time and energy is used taking care of symptoms rather than living in a way that's meaningful. So values life directions get put on hold very often, while that same energy is spent then revolving around pretty much futile efforts to eliminate or control or get rid of chronic or acute pain. And this is evolutionarily reinforced. This is an evolutionary perspective on why avoidance is adaptive and then reinforced, and why we do it with pain. We need to survive, right? So we learn to avoid things that are painful and are dangerous. And we become very, 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 very good at it, almost too good at it. As we've learned, human beings are very, very complex, right? So one of the most complex aspects of our experience is language, and that's out of the scope of today, but understanding that this has an influence in how we experience an avoidance of pain. So if an individual is unwilling to think about their pain or think about their feelings of stress, consider all of the events that then are associated with these symptoms that we would also need to be avoided, like doctors, medications, symptoms, work-related events, work activities, physical movement. That web becomes very big of all of the things that we then need to avoid. Pain and suffering from this perspective are not the same. ACT has, acceptance and commitment therapy, is heavily influenced by Eastern approaches to Buddhism, then really Western Buddhist psychology, which is not really the same, but there's a lot of important messages that we have taken and molded and used in this third wave approach. The main one is that pain is inevitable, suffering is not, right? So then suffering arises from this like experience with grasping and releasing, and then the releasing of the suffering. At the end of the day, suffering is different than pain, and that's a really interesting way to look at our experience. Suffering is often caused by our reaction to pain, the pain that is inevitable that shows up in life. So our personal suffering then includes something like anxiety and fear and confusion, and then getting hooked and feeling that over time. One of my favorite metaphors that I use often is this 2 arrows metaphor, which is at any given time, there are 2 arrows coming at you. The first one is the inevitable pain that shows up in life, like a diagnosis, an injury. The second arrow is our reaction to the first arrow. So how do we work with that second arrow? So from this perspective, pain is not the problem. The struggle with pain is the problem. And that's what we are targeting in acceptance and commitment therapy. In this next section, I'm going to go over a few of the things that we see typically show up in our pain patients that you might want to look out for if you start working with them. So in general, chronic pain is pretty worldwide, 10 to 25. I think that's an underestimate of the experience of pain, higher on the end for back pain. And the medical definition for chronic pain is chronic or persistent pain. Let's see, I have it right here. Chronic pain, persistent pain is pain that carries on for longer than 3 months despite medication or treatment. That's the definition. It's not a very good one, but that's all we got. That's what we've decided on over decades and decades of research and clinical work. It's just pain that lasts more than 3 months. That's our definition of chronic pain. How do you measure that? Not sure. There's a slide at the end of the presentation. We'll talk about assessment. A lot of the research I do at NIH has to do with assessment of pain because it's nearly impossible. Right now, we have no good objective measurements of pain, and our subjective measurements, I'm not sure that they're actually measuring pain, but rather our experience with pain. All important dimensions and constructs, but there's really no good way to measure pain at the current moment. So sometimes what we see emotional functioning with chronic, or the pain impact, social functioning, identity, and some treatment concerns. So I'm going to give you some examples of each one of those. So the emotional impact, the emotional functioning within pain impact is really important for us, and it oftentimes shows up. So I'm going to read you a quote. "This pain has pushed me to my breaking point. One night while riding in my car, my mind was so overwhelmed with that pain, I reached up and tried opening the door so I could jump out of the car. This was not a suicide attempt. It was an overwhelming thought. My pain was so severe that the only way I could cope with the pain was to slam my body on a hard surface at 65 miles an hour." Or this one, "A good day is a day I do not research assisted suicide or look into moving to a state that has legalized suicide for chronically ill patients." Like I said before, social functioning in the system within pain is such an important aspect of this work. For instance, some of these quotes: "I am in constant fear of anything touching me, like people who are huggers or waitresses who like to pat you on the shoulder. He didn't put me down as an emergency contact because he knows I can't be there for him. My extended family and some friends believe I'm just addicted and not actually sick because it said so on the news. Friends and family no longer come around because it's too hard to see me hurting." Within the pain world, our sense of identity is really important to work with. And one of the things that we do in ACT is creating a flexible sense of identity. Illness identity, this construct of illness identity, is seen often in these chronic pain patients. For example, the quotes here: "I went from being a mom, wife, and an executive at the peak of my career to spending nearly every moment in the daybed in my family room. Or I used to be a massage therapist, and now I can barely rub lotion on my own hands. And then finally, the last kind of construct that I want to highlight within this patient population is treatment concerns. So, for example, opiates have been the one consistent medication that has no side effects and allows me to live my life in a productive manner. Notice your own thoughts that come up when I read that. Just notice some of the reactions that you might have as I read this quote. Or the doctor said, I was not worth losing her license over. So she started weaning me off my pain meds where I was stable, which resulted in attempting suicide because my pain was so unbearable. Who am I beyond my pain? Who are we beyond our pain or the broader scope illness? Illness identity, excuse me, I'm just going to take a sip of water. Illness identity as a construct is the degree to which a chronic health condition, like chronic pain, is integrated into somebody's identity rigidly. Rigidly is the key word. So this quote here from curetoday.com, Amanda, who has done a lot of writing, is, I remember the first time I overheard someone call me a cancer patient. I felt like this huge label was slapped on my forehead and my name had been changed. The cancer patient label really threw me into a mental jail. So illness identity is integrally tied to visible signs of illness or injury, like chemo-related hair loss, steroids that cause swelling, loss of mobility, amputation. One of the assessment tools that I do like to use, and I'll give you a list at the end, is the illness identity questionnaire. You're going to see as we go through this, how much of these constructs are going to be related into how we work and act. Like, I just avoid thinking about my illness, or my illness dominates my life. My illness prevents me from doing what I really like to do. Oh, we're already sounding like ACT. So this is an assessment tool that I really like to use. So how do we conceptualize pain from an ACT model? So I'm not going to spend too much time on this. I just threw it up there. This is the ACT hexaflex that I'm sure if you've been here, you probably have attended or do ACT work or attended an intro to ACT pain workshop. But this is the hexaflex. These are the 6 core processes that create something called psychological flexibility. And psychological flexibility is a construct of well-being and our ability to be open, centered, and engaged with both of our internal experiences and our external world. And that construct of psychological flexibility is related to a lot of outcomes from the research perspective. But I'm not going to really go into this in super detail. Where I often start with any type of patient, but mostly I just see patients with pain and chronic illnesses, values. This is a great place to get going, because what I have found is that in the world, there is only one thing that is more powerful than our want and need to escape pain, and that is the things that we care deeply about. That is the one thing that I have found. And so how do we harness those things? And would we be willing to shift, expand, move into some of the hard stuff if it got us closer to these extremely powerful intrinsic motivators that we might call values? And so I love this quote, which is, We've been wrong about what our job is in medicine. We think our job is to ensure health and survival, but really it is larger than that. It is to enable well-being. And well-being is about the reasons one wishes to be alive. Those reasons matter not just at the end of life or when disability comes, but all along the way. And so if we can get in contact with it now, we can have that as momentum for the rest of our lives. So when we think about values are not goals, right? And there gets to be some confusion there in particularly in ACT work. If you have not read A Man's Search for Meaning by Viktor Frankl, I highly suggest it. I try to read it at least once a year, and it is the most influential book of my entire life. And what that book particularly talks about is Friedrich Nietzsche's phrase or philosophy that those that have a why can bear almost any how. Okay. And that is a really interesting concept about the impact that values might have on our experience with pain and life. And so goals are a little bit different. Goals are not values. Goals are specific desired events, things that can be obtained or not. And that when goals are in some sense achieved, they're complete, like a house, a job, a marriage, a training goal, a marathon, a mile. I don't know what I would never get a marathon. Maybe it would be more like a mile for me. Whereas values are kind of more of like chosen life directions, like the way in which you want to go forever. So they're not necessarily achieved. You're never going to get to a value and be like, oh, I've done it. I'm good. I don't need any more. Like I've done the value thing. And so something like working effectively, like I like using verbs and action-oriented verbs, like communicating honestly, loving someone openly. These are always available to act upon in any given moment. That's why they're so important. Values in general are deeply personal, and we have a deep sense of wanting to choose them freely. Some of the early work that I might do with clients is understanding what values they feel like were imposed upon them based on messages they received maybe in their family unit growing up, and which ones are actually theirs. Valuing, and I like to use that phrase more because I feel like it's a verb. Valuing is a verb, are central to ACT, because in ACT we're trying to understand if our behavior that we're doing in this moment provides an effective means to a desired end, and that desired end involves valuing, getting us towards those things. And we cannot assume that we know somebody's values. For instance, I love the metaphor of like choosing your favorite ice cream. Like you might say your favorite ice cream is like chocolate chip cookie dough, and I might say mine's chocolate. Yours aren't wrong and mine aren't right. It's just a personal preference. And you might have noticed that I haven't really mentioned pain within values, because valuing is about what they want their life to be about. I highly doubt somebody wants their life to be about the struggle with pain. Maybe, I'm not sure, but I haven't seen it so far. This is just a resource that I use a lot in my values work. This is freely available on the internet. If you type in Russ Harris complete set of ACT handouts, maybe the first thing that comes up on Google is that, or a big 80 long resource book. This is in that, so you can take that freely from the internet. And this has been a great way to look at values into verbs, so like accepting, adventuring, asserting, caring. I love this kind of conceptualization of values. And so at the end of the day, values is how do you want to show up in your life? So we can use these sections as breaking out how we want to approach values. These inherently, I don't feel like are values, but rather they're a tool to help us piece together the world, because what I value in my family relationships and how I want to show up for that might be different, probably is going to be different, maybe, is than how I want to show up in my social relationships or how I want to show up in leisure or community. Tied directly to values is committed actions. And committed actions are your behavioral goals. We might use SMART goals to get there. But how do I know that you are moving towards a meaningful life? So if I was a fly on the wall in your house, how would I know that you're moving towards communicating openly with your partner? How would I see that? So we might set something like SMART goals or behavioral actions. But that poses a really interesting question, which is, if you're with your client you've identified their values and aligned the behavioral actions, and yet something is getting in the way. We've all been there with the people that we work with. We know what it is that they want and what they could do to get there, and yet something's getting in the way. So what is that? Oftentimes, it's our overly helpful minds that get in the way. So thoughts like, it's my fault, the doctor got it wrong, I should be able to fight this, life should be fair. I'm working with someone that's really struggling with the fair thought right now, or why me, or the self-blame, I should have gone to the doctor earlier. These are all examples of that overly helpful personal assistant that is our mind. It's the part of our experience as humans that tell us stories, capture our attention with thoughts and images, ideas, opinions, judgments, and they may or may not be true, but we often learn to pay attention to them as if they are true or facts. So in order to briefly show you this experience, I want to say for 30 seconds, close your eyes, and I want you to watch what your thoughts are saying. Okay, come back to me. It's a really short but interesting experiential exercise, which highlights that at the same time as our mind continues to run and talk and give us language, one lifetime long grammatically incorrect sentence, at the same time, there's also that part of you that can notice that. That's the part of you, that perspective, that stance, the observer, is the part of us that we are really going to get in contact with. Because these thoughts, these ones, they've probably been around a pretty long time. And they've been around probably so long that it's not worth arguing with them sometimes. And if we do, you've been around them long enough, well, you're probably better at arguing them than me. If any person on here tries to argue my personal thought of, I'm a huge imposter and nobody cares what I have to say, I have had that thought for decades. I'm probably going to out-argue you. And so what is the alternative here? The alternative from this perspective is working with that noticing aspect of me when that shows up. And what do I do when those things show up? We have rules about our pain. Can you still see my screen? Uh-oh. No. Oh, no. Somebody help.
One moment. The computer just decided to, this is a useless computer, so it just decided to restart. So just give me one moment.
That's okay. I'll take a sip of my water.
If you are feeling up to it, Amanda,
Yeah.
We did have a question about, so Nicole asked if it were possible to expand on your approach to the cognitive thought, life should be fair, because Nicole finds herself struggling with that one too. It's a common thought
Yeah,
that comes up, like how might
yeah,
you work with that?
yeah. I love that you asked that. I'm sorry I didn't see it in the chat. So thank you, Andy, for kind of bringing it to my attention. That is a completely reasonable thought to have, right? I don't know if it's true or not. It's very likely that it is or isn't true. I have no way to tell. How is that thought feeling in your experience? Is it feeling very heavy in a way that when we pay attention to it, our behaviors then change in order to get rid of it? Because that's a really painful thought. I'm never going to say that that's not a painful thought. And can we learn from some of this perspective to recognize that thought as a thing that's happening and in our experience as our mind, and then hold it a little bit lighter out here so that way we can notice it? Our thinking and our thoughts are learned behavior. I know that's crazy to think about, and maybe one of these webinars we could do a talk on relational frame theory, which is a theory of human language and cognition from a behavioral learning perspective. If I walk through this door right now and I stub my toe and I trip and I go, oh crap, I probably would use stronger language than that. Oh crap, that really, really hurts. It's very likely that the next time that I go through that door, I'm going to think, oh, I stubbed my toe and that really hurt. And so understanding that you are not that thought, and that's a thought that is occurring in your experience. And then can we have a workability to that experience in a way that you can continue to move through your life? Never ever going to say that that's not a painful thought, because it is. It is. So I hope that answered your question, and I'm happy to talk about it more. I struggle with that one as well. Okay, so within the pain work, our pain we have rules about and we have stories about. I'll often ask people, growing up, what are some of the things you learned about pain? Or I might ask somebody, how did you see your parents or your caregivers or your siblings work with pain? And I'm trying to get to what rules and stories have been reinforced in their life about pain. Oftentimes it is, from what I said at the very beginning with the medical model, is don't have it and get rid of it. But there are more subtle ones that we want to work with. So for instance, we can look at rules and then what the rule leads to from a pain experience, like I can't work if I'm in pain. That's a big one. And if we hold that rule very rigidly, it leads to, once the pain is gone, I'll go back to work. And that is really hard. Or for another example, feeling pain is unacceptable, is the rule. I can't live a good life with that feeling. Therefore, that means I have to get rid of the pain before I can live a good life. Pain is not an option, or exercising is not an option. While exercising while in pain is not an option. So I won't exercise until I'm out of pain. I see this with a lot of people that I work with migraines, because pain and exercising can be helpful, and it also can exacerbate pain. So really getting to the crux of what rules are showing up inflexible in their lives. So you can see from some of those barriers that show up with our pain patients where that might fit in the ACT model, right? So if you are aware of this model and you have an understanding of that model, some of the unhelpful thoughts, right, could be in that cognitive diffusion space, or the self as content space, or the diffusion and self as content space, right? Or the rules and the acceptance or experiential avoidance of it. I really like, and I think it's really important to work with cognitive diffusion with patients that have pain, because cognitive diffusion is when we untangle from our thoughts, a little bit like the the world is unfair, or mine is I'm a stupid idiot, right? So untangling from that and describing thoughts and thinking, looking at your thoughts rather than from your thoughts. In ACT, it's really important to understand that we work with thinking, the process of thinking. We don't actually work with the thoughts. And what I mean by that is that how do we go from, in our pain experience, something like our thoughts like this in our experience. It's going a little slow for me. I don't know if you guys can see that, but I hate pain. I can't move forward until the cancer is gone or pain is gone. I want it gone. Those thoughts in our experience, or I'm a big stupid idiot, those are right here. And they are screaming for my attention, right? Thank you for helping me, evolutionary perspective, because I know you want to keep me alive and you don't want me to have pain. And they are right here, and it's like a siren right in front of our eyes. And so the experience of cognitive diffusion and some of the interventions we can do moves our thoughts from here out to here, so that way we can see other thoughts and other human experiences. Like, I love spending time with my family. I feel present when cuddling with my pet. I put that in there because I love my pet. I find meaning when connecting with others. If you've noticed, I didn't change any of those thoughts. They're still there. I just allowed, through something like a cognitive diffusion technique, for them to become out here so that way I can see the whole realm of human experience. And it is varied. We have a lot of human experiences. Our pain-related stuff ends up being right here, right? So we're not changing it. We're just noticing it from a distance, so that way we can see the rest of what the world has to offer. Avoidance is a really interesting concept within pain work, because we are trained to avoid pain. And if you've ever worked with somebody that has chronic pain or acute pain, they really oftentimes have a huge challenge of being in their bodies. They don't want any part of it, understandably so, right? And avoidance, on the other hand, like opting out of activities, which happens a lot, or opportunities or interests, some withdrawal or efforts to minimize, excessive use of distraction, sometimes even substance abuse, drugs, alcohol, exercise. These behaviors are not problematic in themselves. They are problematic when they interfere with daily valued living. And so one of the ways that we can work with that is through something like acceptance. I gotta say, don't love the word acceptance. I have, based on my own learning history, a lot of different connections with the word acceptance. So I have found that willingness instead has worked better for me, that term willingness. Whatever works for you. Again, another time, a relational frame theory webinar would be really cool about the impact of language and how we get there. But acceptance is not liking, resigning, resignation, or tolerating. Acceptance is willingness. And I love this little slide, or this little, okay, yeah, it's showing up. I send this to like literally everybody. You can't get rid of your fears, but you can learn to live with them. Bring them to tea, right? Like, I'm not going to get rid of the fear that I'm an imposter and nobody cares what I have to say and nobody's going to learn anything, but I can let it into the room, because that's a long one. And maybe what that thing is trying to tell me is that I'm scared, and that's okay, right? So I print this out for, like, especially my kids that I work with. They love this. Acceptance plays a crucial role because we cannot get rid of our experiences, right? We haven't figured really that out. If we do, like, bring me in on it, because we could go 50-50 and be total millionaires, but haven't figured it out so far. So while we typically know this is true for physical pain or a diagnosis, it's even something as abstract as thoughts, right? So I put this because now I want you to, just as a small example, I want you to, if you're willing, close your eyes and then don't think about the pink polar bear. Just like, don't do it, and do whatever you need to do to not think about it. right? And then come back to me. Really, really short. I will do this with clients sometimes. I'll often do it in group sessions, because what it shows is two things. One is we might be able to get rid of it, but we have to try really, 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 really hard and use all of our cognitive resources to think about something else. And then that's if you're lucky. And then if you're not, it doesn't even matter, because we're not getting rid of it. And so if we cannot accept our physical sensations around pain, our thoughts around pain, we will then spend our entire lives trying to get rid of it. Right? And think about all of the things in our lives that end up being associated with pain that we then have to get rid of. So we have migraine pain. Based on learning and a web of relations, we then, if we avoid anything to do with migraine pain, we have to also avoid all of these things. And if we go and avoid all of these things, our lives and the possibilities of the things that we can interact with do become very small, and our lives become small. ACT is about broadening the behavioral repertoire to have the most flexible lives possible and the most amount of opportunity to behave in a way that gets us towards our values. When we start feeling like we're going like this, we're going in the wrong direction. This is a exercise that I used to do a lot when I was working at a partial program for pain and substance abuse. And I have found it very, very, very interesting with some individuals. Pick and choose wisely. This I took right out of Kristen Neff's self-compassion book. This is an exercise that she has in her book that I just have found to be so cool, where you give a participant, a patient, a client, and yourself an ice cube, and you put it in your hand. And then when it becomes to the point of intolerance, you throw it in the trash. And then you teach them some self-compassion or acceptance, present moment awareness, expansion tools, a new form of curiosity to their experience, perhaps give them some new language, and then have them hold the ice cube in their hand again, or the other one, depending on how much time is left, and see how long they can do that for before it becomes intolerable and they throw it in the trash. What you will often find is when we add something like self-compassion, mindfulness, acceptance, we are able to hold that experience of the ice cube longer when we have that, compared to when we have, oh crap, this is horrible, I want nothing to do with this. I love Kristen Neff. I use her materials a lot. Yes, me too. She's amazing. The whole self-compassion world is amazing. Considered ACT's cousin, fits so well into the ACT model. As humans, we get so caught up in the past and in the future. This is particularly true for patients that have pain. And it's wonderful that we can do that and that we have language for memory. That's really cool. And it also makes us really experience a lot of distress when we're caught up in it, because life does not exist in the past or the future. Life exists in the now. That's it, always here right now. And so we can get caught up in resonating with some of our thoughts, like, where did the pain come from? Or the last time I did this had pain. Or I work with somebody who her medical team made, at the time, choices based on the information that they had that ended up not being good for her. And so she often gets caught in, if they would have just known, or if they would have just did something different, right? Or and then on the flip side, what if this doesn't resolve my pain or illness, or my pain is going to come back? When will it go away? Or if I could just get this discomfort to go away, I can live a values life. Either of those we're not contacting here. The thing that we have in front of us in this moment, the thing that's changing constantly. And then finally, with from this ACT perspective, it's really important, which is going to tie into that illness identity construct that I talked about before, which is something that we call the contextualized self. The contextualized self is identifying often as a thing, like we identify as a thing. So I often hear, I am a pain patient, or at the beginning, you might have noticed some of those quotes, I am a cancer patient. And so moving into the contextualized self is an opportunity to add flexibility to that in a way that we can see ourselves at any given time as a friend, a parent, a sibling, a lawyer, a gamer, a dog mom, an auntie, whatever it is in any given moment with flexibility. And that takes place by getting into contact with something we call the observing self, sometimes called the transcendent sense of self. The transcendent sense of self is a perspective through time. So if you go back in your memories to a memory that you had, earlier today when you were eating breakfast, or last night when you were getting ready for bed, or 7 years ago, or 20 years ago, we can have those memories as if we've experienced them. So that sense of self is fluid. That is the observing perspective. That is the contextualized self. And so can we be that vessel in which contains the fluctuating human experience? I have the picture of the sky here because this is one of my favorite metaphors for the contextualized self, in that the sky has clouds, lots of clouds that go through it. Sometimes it has tornadoes. Sometimes it has hurricanes. Sometimes there's rainbows. I love rainbows. So sometimes there's rainbows. Sometimes there's rain that pellets down. And yet the sky holds it. So the contextualized self is the sky. It's not identifying particularly as each one of the clouds or as each one of the storms. It wants to sometimes, and getting back into that expansive view of the sky. That is that contextualized self, that observing perspective that we're trying so desperately to help our clients move into. And so from this perspective, pain and injury and illness is not larger than who we are, but it is a part of our experience contained within me. So what is our experience as human beings? And then a side quest is our experience with pain. So I am experiencing pain-related symptoms right now. That's a really good indicator that we're in contextualized self. So what we're trying to do from this experience, from this perspective, is when we experience pain-related symptoms, and excuse my spelling right here, I made these slides after I got surgery, so you can imagine my spelling was not great, but when we're working with pain, we go from pain to likely, oftentimes when they're coming into our door, an avoidance-based behavior to get rid of pain. And so from this perspective, all we're trying to do is create space between the experience of pain and the behavior. So that way we can see all of the other behaviors in our repertoire, in the realm of possibility, and then choose the one at the moment that gets us towards values-based living, rather than just a contingency of decreasing or avoiding pain. That is the whole goal. That's what we're trying to do. So as we conceptualize from this perspective, one thing that I wanted to add was the experience of mindfulness, because most people, when they think of ACT, they also think of mindfulness. And what I want to say about that is that mindfulness is a part of ACT. ACT is not mindfulness. So in our hexaflex, the processes on the center and left side, like acceptance, cognitive diffusion, the observing sense of self, the contact with the present moment, those are mindfulness-based processes. So when we do mindfulness as an intervention, we're attempting to strengthen and broaden these processes as a part of psychological flexibility. And so we might integrate mindfulness into our clinical interventions, so that way we can kind of work with opening up and strengthening these mindfulness processes of ACT, of psychological flexibility. I have found it particularly helpful to integrate movement-based meditation in work with chronic pain patients. I was trained by a a licensed therapist, but also a licensed like dance practitioner, and who focused on chronic pain. And she integrated the two into what we did training in Qigong, but went into a little bit more flexible with it, but movement-based meditation. I have found it to be extremely helpful, because when we work with our bodies and with pain, a lot of times our minds and our awareness, the mind's eye, really doesn't want to go to that point in the body. And so how can we use something like movement to allow and to expand our ability with compassion and openness to get back into our bodies in a way that isn't like rigid in a way? So I have always loved integrating something like Qigong into my sessions, or meditative movement. Yoga, if you're trained in it, amazing. And then there's also, formal eyes closed meditations that have been particularly helpful. I do a lot of work with people who are in their beds or bedridden, or I go to see them inpatient and I sit beside their bed in a hospital wing. So I have found myself using a lot of informal meditative practices with these clients, and they are also amazing. So something like even just eating or taking a shower, washing your hands, I can even break it down to something like holding a pen and just drawing a line on a paper in front of me. If we have like one of those trays that go over their bed, we can integrate mindfulness even in these circumstances. So what I'm going to do now is I'm going to show you how I might conceptualize through this ACT perspective somebody that might walk in through my door. So this example, I guess we'll see if we have time for both. So this example is a woman, changed her name, who had gastric cancer. And so what they did is they did a total gastrectomy and they took out her stomach. And post-surgery, she had bile reflux because she no longer had a stomach. So bile reflux, she had increased abdomen swelling and pain and nausea. And in addition, she also had life stressors that included her mother dying from the same condition, her daughter undergoing the same total gastrectomy. And she was referred to me because she was no longer eating or drinking or taking her meds because it was producing a lot of bile reflux and pain. So if I take the ACT hexaflex, I might look at each of these processes for conceptualization. So I could find that she did not want to have bile reflux. She did not like the chalky feeling from the meds. She did not want to drink because it instantly made her full. That's telling me we're in the realm of acceptance and experiential avoidance, rather. She would continuously say things as rules, like, this is how the world functions. If I eat this right now, I will throw up. And you may throw up. Or I hate the way this tastes. I can't eat if I'm hungry. I can't do chores if I'm nauseous. Anytime it feels like a rule, we might be in the area of cognitive fusion. She got really caught up in planning out her day to avoid mishaps. She would focus on storytelling. Anytime you hear a story over and over and over again, we're really not in the moment, I think. And she would also focus on when she could she had a feeding tube, when she could get it out, the future of getting it out. I want it out, I want it out, I want it out. She saw herself as the label cancer patient, or she said something to me like, I never thought this would be my life. So we're attaching ourselves to identity in a really inflexible way that is painful and hurtful and distressing. That is distressing. She did come to me with clarity about what her values were. I might have helped her use different language, but she had a lot of values around independence, strength, family time, and caregiving. But she then spent all day in bed. She was not eating or drinking or taking her meds, and she did not want to talk or spend time with friends or family. So some ACT-based interventions for this might be something like name your brain, that allowed her to get out of the embedded content in her mind. So something like, I worked with somebody and she, to this day, this was years ago, and I just got a message from her recently being like, Edna, I like Edna is like really acting up right now because she had named her mind Edna, and Edna was like a lot of health anxiety related thoughts. So something as simple as naming your brain allows us to take a step out of identifying with the content of our thoughts and into observing when it happens. Or even just simple language like, I'm noticing that I'm having the thought, or I'm noticing my mind having the thought that I don't want bile reflux, or I'll throw up if I eat this, or I hate the way that this tastes. And then there's also funny ones like sing that thought, or say it in like a famous character's voice. I will save you all from the torture of me singing in this webinar, maybe the next one. We also did some mindfulness-based exposure, which is is this like the metaphor Aunt Edna in ACT? I'm not super familiar with that metaphor. If you type it into the chat, I will let you know. Mindfulness-based exposure can be really important with pain. It's a little bit different than our traditional CBT-based exposure in that we are working in a systematic, step-by-step way to increase awareness and expansion and willingness and compassion around a human sensation, just as practice. And so something like spending a lot of time in meditation. I once worked with a woman, it wasn't this woman, but it was somebody else in a similar diagnosis. And we did a meditation around eating mashed potatoes. And so noticing all of the thoughts and sensations that show up when we're looking at it beforehand, when it's on our spoon, when it's getting close to our mouths, all of the things that show up in a perspective, with compassion, when we even eat it, what shows up for us, and slowing it down. You're trying to have a party and that is ruining it. Yes, yes, that is very similar. I love that. That also has to do with acceptance and willingness. There is that exact metaphor that Aunt Edna, I think online this YouTube video, but if you Google the unwanted party guest on YouTube, there is that metaphor in illustration. And I have shown it to people and they have loved it. So if you like that metaphor, I hope you have found that YouTube video. Okay, so the second example. Actually, I'm going to skip through this because I want to make sure that we have time for questions at the end. So I'm just going to skip through it. I'm sorry, everybody. Okay, so pulling it all together. So the ACT hexaflex, right? We talked about what each of these means in concept in relation to pain, how it might show up with a person of pain, what likely might be going on with their experience within the system. At the end of the day, this hexaflex might seem complicated if you are new to ACT, but what it really means is there is suffering that is happening based on cognitive fusion, what thoughts we're having that we're really sticking to, we're identifying with, experiential avoidance and unworkable action. And through something like workability, which is what we're doing, we're making space to understand the behavioral repertoire and choosing the behavior to get us closer to what we want. Through that workability, we get to vitality, which is being present, opening up and doing what matters. This is ACT. That's it. That's what we're doing. Pretty cool, huh? If you are interested, if you have found that any of these things resonate with you, then I have some resources for you. Oh, actually, first we're going to do assessment. Never mind, not resources quite yet. The thing I just briefly want to say about this is I have found in my experience to have process-based measures be most helpful for understanding what I want to know about a chronic pain patient. With that being said, something like the chronic pain acceptance questionnaire gives us valuable information about some of these ACT-based processes in relation to pain. So I'm not going to go too much into this, but my favorite one is this chronic pain acceptance questionnaire. You can use something like the NRS scale. I have found it not to be super helpful because it reinforces a numeric rating scale, which I don't really feel like crosses over from patient to patient. And then also the system in which I'm asking that. So what is the reinforcement? What are they going to get out of a certain number? has not found to me to be helpful in the work that I do as a psychologist. Instead, I have found extreme help with something like the chronic pain acceptance questionnaire, like I am getting on with the business of living no matter what my pain level is. That's clinically useful information to me. Also, that illness identity questionnaire is really interesting in this population. And then there's some just general ACT-based measurements that I might give to a patient over the course of treatment, like the brief experiential avoidance questionnaire, et cetera. And if you like this and you want to do more of this and you want to know more about this, there are some resources I have. First one is ACT for Chronic Pain by Joanne Dahl. This is for practitioners. This is really, really good. Really does a good job, a little bit outdated, but does a good job of understanding the system, the medical context. Also gives you eight session protocol, so it might be worth it. In addition, as like a adjunctive to this, there's the patient workbook, which is Living Beyond Your Pain, which is also Joanne Dahl, so that you could actually have a patient work with this. Also gives you a lot of good exercises if you're an exercise person. That gives you a handout for some working with pain-based rules, if you thought that that slide was particularly interesting. The only other ones I wanted to say were Whole Catastrophe Living, which is really big, but it comes on audio tape, which is John Kabat-Zinn's work with MBSR, which is highly influential to me in my experience with working with pain patients. And then on here, I believe it's open access, but a couple years ago, I want to say in the pandemic, but it still feels like we're in the pandemic. I wrote, along with some colleagues, an article on how to use ACT for chronic pain within the context of COVID. And it gives you some interesting and helpful resources and clinical applications to using technology and using it as a metaphor and things like that. I believe it's open access. If it's not, email me and I'll send it to you. If you are very interested in this, feel free, please join ACBS, which is the professional association. Yes, I believe we're still in the pandemic. I feel that way too. When I said that, I was like, I still feel like I'm working from home. There's a pain SIG in ACBS. So join that one. Cancer SIG, I love. If you work with cancer patients, I'm president of that one. Health SIG. So I gave it to you there. I always end with my email. So those are my emails. Email me if you're interested in this or you have questions. I will talk about this for days. So please write this down and email me if you want to continue the conversation. I always end my ACT-based PowerPoints with my values, which is having fun with my husband and my doggy Carl. And at the end of the day, if you've only taken one thing from this workshop, it's, would you be willing to show up non-judgmentally with compassion to pain in order to do what matters to you? That's what we're talking about here. So on that, I've left 3 minutes. 3 minutes. I'm not sure we're going to get to questions, so I might have to email them. I think Andy said that if there were any lingering questions, that I can answer them and we'll post them. I know they have a few announcements, so I'll shut up now.
Wow, that was so great. Thank you so much, Dr. Rhodes. So we don't really have a ton of time for questions, but I have been capturing the questions that folks put in chat. And maybe I can twist Dr. Rhodes' arm and she can be willing to have that pain and answer some of those questions. And we can post those along with some of the other resources that you mentioned.
Definitely.
All right. Well, thanks again so much for being on CDPP. I'm going to hand things over to Mr. Norgard in just a moment to tell you all about CEs, but thanks again for being with us, Amanda. That was great. And I heard you say something about doing a webinar on RFT, relational frame theory. So everyone heard it. So we have to bring you back to do that.
That's my other passion. ACT for chronic pain is one passion. RFT is the other.
Awesome.
All right. Thank you for having me, everyone.
All right. Thank you, everyone. And again, thank you to our wonderful presenter, Dr. Rhodes. In order for you to receive continuing educations, we'll close the room here exactly at 1:30 p.m. The system will update usually within a few minutes. Refresh your browser, log back into your My Account page through CE21. Go to the same seminar that you were at today, click on the orange certificate button, complete the evaluation, and then you should be able to print out your certificate or email your certificate to yourself. If for some reason it states that the seminar is not complete, please just wait like 2 hours. Sometimes it takes a little bit longer, and we'll be taking attendance as well. After that 2 hours, if for some reason it hasn't tracked it, go ahead and reach out to myself. My email's up there on the screen, and I'll post it here in chat before I close out the room. If you have any other questions, go ahead and pop them in. So I went ahead, pop my email in there. If you have any questions, go ahead and email. Otherwise, the room will close in about 25 seconds.